Spinal anesthesia, so it is an important short note, okay, asked 7 times. So it is the injection of local anesthetic into the subarachnoid space. So what is subarachnoid space? It is an empty space. No, it contains a cerebrospinal fluid, okay. So literally means we are injecting this local anesthetic into this cerebrospinal fluid, okay, which cause loss of sensory function, motor function and sympathetic tone. What kind of local anesthetic we are using? We are using lignocaine or else bupivacaine. In my hospital setup, bupivacaine is most commonly used. Okay, the position of the patient is very important, which is lateral liquidus position with all flexion. Okay, flexion is important, so as to open the interlaminar space. Okay, so during this is the position in supine position. Okay, this diagram is in supine position, and when the patient is flexion, which means flexion of head, flexion of hip and flexion of knee, so this cause opening up of lamella space, so it is easier to inject the needle. Okay, the anatomical landmark, which is very important. So this is the view from back. Okay, so this is the posterior superior iliac spine, which you can well palpate. Okay, you can palpate this from back, and you have to palpate in the both side, and you have to draw an imaginary line. So this imaginary line corresponds to L4 vertebra. Okay, L4 vertebra, remember, it's very important. So look at this diagram. So see, L1, L2, L3, L4, L5 vertebra. So this is the nerve root. So this is L1 nerve root, L2, L3, L4, L5 nerve root. Okay, so we have to inject the needle either between L3 and L4, okay, or between L4 and L5. So see, this is the spinal cord. Okay, spinal cord ends at the level of L1, but we are injecting this needle here, so we are not causing any damage to the spinal cord. Okay, spinal cord is safe. So after injecting this anesthetic, all the nerve roots will get anesthetized, and no sense, no motor function and sympathetic tone will be there. Okay, so the technique is 24 to 26 gauge needle with stellate is used. So in my hospital setup, Quinke's needle is used. Okay, so what is the layer that the needle pass through? The needle pass through skin, supraspinal ligament, interspinal ligament, ligamentum flavum, then epidural dura arachnoid, and then subarachnoid space. This is actually the target. Okay, so look at this diagram. Okay, so see, this is the spinous process which you can palpate. Okay, which you can palpate and find out the level of vertebra. This is the spinous process, and see, this is the ligament which is called supraspinal ligament, because this is spinal process, this is supraspinal ligament, and this is the interspinal ligament between these two spinal process. So it is called interspinal ligament. Okay, interspinal ligament. Then this is the ligamentum flavum. Okay, so this is the needle. We are piercing this supraspinal ligament, interspinal ligament and ligamentum flavum. Then we are entering the epidural space, and we are piercing the dura mater, then arachnoid, and then we are entering into subarachnoid space. So subarachnoid space is where it contains cerebrospinal fluid. So after entering this space, the cerebrospinal fluid will leak at the rate of 0.5 ml per second. Okay, you can literally see after injecting the needle up to here. Okay, and then you have to rotate the needle 360 degree, and then you have to inject the drug slowly. Okay, so the advantage is hypotension reduces the bleed, which means this spinal anesthesia will cause dilatation of the blood vessel, which leads to hypotension, which reduces the bleed during surgery, and adequate relaxation is achieved, and respiratory complications are less. And disadvantages is CSF leak can occur, infection can occur, and aseptic inflammation can occur, which leads to headache, inflammation of meninges, which leads to headache. Okay, and then contraindication when the patient is allergic to lignocaine. Okay, cardiac patients, sepsis and spinal disease and neurological condition.